Hello, everyone. Good afternoon, good morning, good evening, and thank you so much for joining this virtual dialogue today. It is a pleasure to be connected with you all, to see many familiar names and faces on the call so far. So for those of you who don't know me, I'm Kirsty Graham, Director of Capacity Building here at UICC, the Union for International Cancer Control. Before we move ahead, I'd like to bring your attention just to a few housekeeping items. So UICC's virtual dialogues are hosted as meetings, and as such, it's possible for you to see everyone who is on the dialogue to engage with each other and with the speakers. So in light of this, it'd be great if you could keep your cameras on if the connection allows, and to use the mute and unmute function when you're talking, and only unmute, obviously, when you're talking to avoid any distractions and background noise. Please also use the chat box and post any questions or comments that you have there during the dialogue. We will be facilitating a couple of question and answer times during the dialogue, and we'll be capturing these questions also. If we can, we'll be able to reach out to you so you can share your question directly with the speaker. So to kick off with the chat, please introduce yourself. I see a few of you have already done so, which is fantastic. I'd encourage all of you to do the same so that people get to know who's on the call and who's in the discussion. So share your name, your organization, and location. So UICC is delighted to be hosting this dialogue in partnership with Jhpiego, and it is really part of a long-standing collaboration with Jhpiego. In recent years, we've collectively co-hosted a whole series of virtual dialogues on cervical cancer elimination, really looking to bring insights and support shared learning across the cancer community in support of the global strategy for cervical cancer elimination. Now, whilst we totally believe that coordinated and focused effort is needed across all three pillars of the global strategy, this virtual dialogue really brings an important focus to the second and third pillars of the strategy. I'm sure you know them well, but 70% of women screened by 35 and age 45 using high-performance tests, and 90% of precancers and invasive cancers being effectively treated. In WHO's recent update on November 17th, it was noted that whilst there has been significant investment to improve access to screening around the world, only 65% of countries include cervical cancer screening services, and additional emphasis is needed to reach and to make progress towards the 2030 targets. So this virtual dialogue will really serve as a platform for the launch of new technical and programmatic resources and provide an opportunity to reflect on some of the learnings of recent years in implementing screening and treatment services, bringing insights from different projects across multiple countries to hopefully inspire further conversations, learning, and future progress. It's now my pleasure to hand over to Maura McCarthy, Senior Technical Advisor from Jhpiego, to share a few further welcome words. Maura, over to you.
Thanks, Kirsty. Hello and welcome. As Kirsty noted, my name is Maura McCarthy and I'm the Women's Cancer Team Lead at Jhpiego. And we're very pleased to be working in partnership with UICC to bring this discussion forward today and to get to hear the perspectives and insights from our panelists and speakers. Today's discussion is really grounded in reflection, but also meant to be rich in discussion on how we collectively move forward towards WHO elimination strategy goals, as Kirsty mentioned. It's been a bit over 3 years since the launch of the global strategy for the elimination of cervical cancer and subsequent release of the WHO screening and treatment guideline recommendations. And I think today we'll get to hear really a four-country panel discussion on how countries are adapting and moving to advance these cervical cancer elimination targets. And as well, the first portion of our agenda will elevate key learnings across the introduction of HPV DNA testing and introduction of thermal ablation thus far. And also, we will take the opportunity to launch some recently developed clinical and service delivery organization how-to tools for those that are implementing secondary prevention programs. And with that, I will turn to Maribel Amante, who is an implementation scientist, cervical cancer elimination initiative at the WHO NCD department, who will lead us through the first portion of our agenda and introduce the speakers. Thank you, and Maribel, over to you.
Thank you very much. Good morning, good afternoon, good evening to everybody. Here we are to see the learning and the challenges that we face and what has been built by the work that both UICC and Jhpiego do worldwide. And with no further introduction, I think I will move to the speakers because we need to keep the time so as to have a nice short discussion afterwards. So first, we will hear the voices of Dr. Veronica Reyes, a very good friend of mine, I have to say. She is a medical obstetrics and gynecologist, and she holds a master in public health and a PhD in international health. She has 25 years experience supporting programs, and she's now the senior technical advisor for reproductive health and women's cancer of Jhpiego. And of course, she brings us a lot of experience, and she is also participating in the Success Project that has actually involved 4 countries in 3 continents. Together with Veronica is Dr. Ana Garces, who also holds a master in public health. She is from Guatemala. She is the founder of the One Voice Against Cancer, which is a Guatemalan NGO that has led cancer prevention and education nationwide in Guatemala. She's the current director of Jhpiego in Guatemala, and she's also, of course, part of the Success Project. So I'll pass it to you both to give us your presentation, and then we will continue. Veronica and Ana, please go ahead. Thanks.
Thank you very much, Maribel, for this kind word. It's really a pleasure to be with you and everyone today to present Jhpiego tools to support the country for the introduction of new technology to advance in cervical cancer prevention. While I'm waiting for Maura to share our slide, I just would like to say that Jhpiego has been working very closely with the WHO, and the tools that we have been developing is in support to the WHO and the global effort for the elimination of the cervical cancer. So, Maura, can you put the slide in the slide? Thank you very much. So the next slide, please. So Jhpiego is a non-profit organization affiliated to Johns Hopkins University. We are currently working in around 40 countries, and those are countries where Jhpiego has been supporting cervical cancer prevention, some in the past and some currently. Next, please. So as I mentioned, Jhpiego has been supporting the development, the dissemination, and use of WHO resources for cervical cancer prevention. And when WHO launched the global strategy to accelerate the elimination, and also they update guidelines for screening and treatment. Next, please. Jhpiego worked to update our tools because Jhpiego has been working in this area for a long time, but we update our tools and develop other tools. This is a list of tools that we have been developing. Here you can see the link where you can access and download these tools to use in your country if you want to. So the list that updates the material include the VIA Atlas and flashcard, the training package, one document with consideration for decision-making for using algorithm for HPV screening and treatment, some tools related to quality and the clinical SOP. I'm going to talk a bit about these tools. Next, please. So I'm pretty sure that many of you have been seen or used this tool that Jhpiego developed a long time ago. It's an atlas and flashcard for training people and provide supportive supervision on VIA. What we did with this material was just to include the thermal ablation, because in the past we had just cryotherapy, and now we have thermal ablation and the cryo. Next, please. So this is one package for to support training. So we have in this training package a guide for learning, guide for facilitators, and the training slides. So these include all of the essential material for organizing and conduct training on HPV testing and the thermal ablation. This material has been used and validated in several countries. Next, please. So as I mentioned, we also had developed this consideration on algorithm for primary HPV screening for decision making, just to explain how to use it and provide some tips on the use of these algorithms. We also developed this clinical standard operation procedure to be used in support service delivery. So we have in the SOP for different essential clinical procedures for cervical cancer prevention. Next, please. So these are two related to quality. Quality is critical. So we developed this guideline in terms of guidance to improve quality and assure quality. It includes definition, approach for quality, core indicators and benchmark, and also tools for supportive supervision and mentorship. Next, please. And together with those documents, we also developed these global performance standards for secondary prevention to assess quality and identify gaps. So we have a standard related to service management for primary service and also for referral service. We can use these to assess and improve quality. Next, please. And this document also includes the summary of all of the essential standards and the color status of the facility. So quickly, someone can assess and see the result, and identify the main gaps, and work to develop action plan for improvement. Next. So thank you very much, and I will be here to respond to any question. Thank you. So I hand on to Anna. Anna, please.
Thank you, Veronica, and good morning, everybody. I'm honored to be able to present a little bit of what Jhpiego has done in different countries around the world and what are lessons learned in what needs to be done for cervical cancer prevention, detection, and treatment at each of the different health services. So next slide, please. Next slide. Can I get the next slide, please? Okay, thank you. So we have, no, sorry, the previous one. We have worked in 10 countries around the world, specifically with HPV-based screening, which is completely aligned with the WHO guidelines, as well as thermal ablation, which is based in 8 different countries. Next slide, please. So cervical cancer prevention and activities are a really great opportunity to work throughout the health services and to provide quality care at each of the different levels of health services. However, it does require coordination ahead of beginning these services to ensure that it all works well. So going through, if you look at the slide, going through from the community up to the 4th level of care, there are, in general, activities that are specific to each of these levels. So at the community level, we need to carry out awareness and counseling about cervical cancer. In India, this can be an ASHA worker. In other places, it can be community health promoters. It's also great if at the community level, self-sample collection can occur. Then at the primary level facility, assisted sample collection can occur. And we also know that all awareness and counseling frequently does need to occur at the primary level facility. Then when we go to the 3rd level, this is where the samples get all together. So it's a sample transport hub. Then the sample testing can occur if it's possible. And then if the woman is positive, this is where the visual assessment and the treatment needs to happen, as well as the counseling and the result on ablative treatment. So it's really great that for women who have met the criteria for treatment with a thermal ablation, this is as far as they need to go, and this is where they can obtain all of the care, which is really revolutionary in comparison to what happened previously. For the women that do need to go with larger lesions or because they have suspected cancer or need a LEAP, then they need to go to the fourth level of care. So this is, I'm a Guatemalan working in Guatemala. This is what the health system looks like in Guatemala. We know that in different places around the world, it can vary a little bit, but in general, this is how it works. So with the next slide, I want to talk to you a little bit about differences in access, care pathways, lab, and scale, and what we need to think about at each of these levels. So at the access point, and making sure that the testing is accessible to all of these women, there are a few points that we need to think about. So in terms of awareness, it's really important to think that counseling and messaging strategies need to be holistic and guide individuals through every stage up through treatment. We found that sometimes women, the message that they get is that they have performed the testing and that's it, they don't need anything more. So it's really important that they understand that this is just the first step. They need to come back to get the results, and then they might need to get treatment in order to ensure that we can really guide them through the whole continuum of care. A specific point which we have really learned about in Success and also in Guatemala is women living with HIV have unique characteristics, and we need to make sure that they have accessible points of care in addition to those for the general population. As far as service integration, it's really interesting because cervical cancer is sort of in the middle between non-communicable diseases and sexual and reproductive health. So it's important that services are integrated across all of these different areas, obviously also with HIV. And the ideal situation is that this be a one-stop solution for patients so that they can get all of their different services at what is physically one single health service, and that they don't have to go through a number of them to get access to care. Then for decentralization, it's really important for self-sample collection. In Guatemala, we had a bit of a struggle at the beginning, but it was really great to see how this was solved. Providers are frequently the most important point to not get self-sample collection. So we really need to work with them and to explain to them that the sample that's collected by this woman is just as good as the sample collected by the provider. And it really has the potential to increase access so much. And then also in decentralization, we need to have quality infrastructure, training, and resource. We know that in low and middle income countries, quality infrastructure is not always the easiest to get, but it is important to think about these different elements when we start. Next slide, please. So in terms of the care pathway, when we are thinking about the continuum of care and patient navigation, as I mentioned, it's really important to make sure that the patient doesn't get lost from one health service to the other. So it's not only the patient understanding that she needs to go through these steps, it's also the providers understanding that they need to really pay attention to each individual patient. And if she does have a positive result, which might be 16 or 18, she can in no way be lost to follow up or not get the treatment. So we really need to sensitize at both levels. That requires frequently strengthening referral systems. For large lesion or suspect cancer follow-up, we know that we're going to detect cancer, and we need to make sure that when we do, these patients can get referred, and that the hospital where they're going to get referred is actually going to work. And because of that, we need to ensure also that the access to these health facilities is critical. Guatemala is a very mountainous country, and a lot of times maybe it's not so many kilometers, but getting there is very difficult. And we know that all around the world, each country has different problems and different issues in getting to access. So we really need to think through these before to ensure that the woman can get access and care as close to her home as possible. If we think about capacity building for advanced diagnostics and treatment, it is really wonderful to see how in 20 years, the capacity for thermal ablation has increased all around the world. Just here in Guatemala, in the last 3 years, it's like become a big boom and has been widely accepted. And also for the patients as well as the providers, we've seen everywhere that the acceptance rate is above 90%. If thermal ablation is not an option because the lesion is larger than that, then we also need to ensure that there's LEAP capacity. and the capacity of providers to handle those cases that might be a little bit more complicated. And same as for screening, reaching women living with HIV also needs to be considered. Ideally, they would go to the same health services as the rest of the population, although here in Guatemala, as well as in a few countries, the two are separate. So we need to ensure that they can go together and that we can effectively get them to treatment. And then finally, when we think about the lab, in the next slide, please. We need to, as you all know, there are a variety of different platforms and there are a variety of different tests available. So we need to ensure that the diagnostic network is really set up to be able to handle that in coverage and in equity. And usually the best solution is multiple lab platforms and models to fit health system context, which is what we have learned in the Success Project. A huge issue with this is the turnaround time from when the woman gets the test done to when she gets the result back. And we know that the closer that the lab capacities are to the woman, the shorter that turnaround time is going to be. However, when it's very close, often the machines are smaller and don't have larger capabilities. For each thing to figure out what works the best. It is important that we don't create different pathways for actually sending the transport. What should happen is that we're using the existing Ministry of Health pathways for the same as for what regularly goes on and for other tests. Then in order to do that, we need to map the capacities in the lab and also increase lab capacities. So Guatemala is a population of 19 million people, and we were surprised to learn that after COVID, we have something like 45 different molecular biology tests. And this was the result of mapping, because we really needed to conduct a mapping and figure out where everything was and what the capacity was. And that information is necessary to be able to plan effectively. And then finally, to take it to scale, in the next slide, this is, well, once you started, you really need to think about how to take it to scale and be able to make this accessible to all women. So this does require policies and service delivery guidelines, and on a national level, so that the whole of the health system can go towards that, including not only the public, but also the private or the social security institutes, NGOs, because frequently these are all the different providers available. And the health workers need tools and frameworks necessary for the effective implementation. So those frequently do require some contextualization to each country. And Veronica shared everything that's available from Jhpiego. Then for the data management, this is very important, as well as the health system integration, to ensure at a national level that there's integration across the different systems. And obviously, we need resource allocation within the government's financial planning so that this can be long-term. So I'm happy to report that in 2024, the Ministry of Health of Guatemala has procured with their own funding about 12 to 15,000 HPV tests. So they're looking at how that's going to be spent. So thank you very much.
Thank you very much to both Veronica and Ana. And we will now pass to Dr. Lisa Juan, also a good friend of mine. Lisa has more than 10 years experience leading programs and research projects, and she is now the director of the Success Project from Expertise France. Lisa, would you like to give us some words on your work under Success? Please go ahead.
Yeah, thanks so much, Maribel. And I just want to say, in the Success Project, which is funded by UNITA, we're really honored to partner with Jhpiego and UICC, and also with support from WHO. So in the 4 countries, Burkina Faso, Cote d'Ivoire, Guatemala, and the Philippines, there's a lot of learnings from the countries. And I want to say that we're really, working on bringing the guideline to the field, to testing, from the different algorithms. And to understand, like Anna mentioned, this really, I would say integration is the key, using integrated approach. We're not creating another program, another vertical program. It's really, we can look at the 6 pillars of health system from WHO and to see how we can integrate cervical cancer prevention into each pillar. So Anna and Veronica already mentioned, I think, from awareness raising and service delivery, every entry point for screening, treatment, and also lab management is a huge component when we're introducing HPV. The whole supply chain management, including also for thermoblations, for treatments for precancerous lesions, these are things to be considered really from the outset. What we're seeing in countries, once again, lab is something that I would really encourage countries when introducing HPV testing to think really carefully. What is your what are the platforms available? What are the capacity? And also, like Anna already mentioned, this sample shipment, those simple things, sample management. How can we do this in an integrated, most resource efficient approach? Data management is really important, and I would also like to mention that coordinations between different national programs is something that we need to, think about from the really beginning, because as mentioned before, cervical cancer is sometimes managed by one part of it by infectious disease department, one part of it by NCD or cancer program, and by sexual reproductive health program. And of course, we have component with vaccination. And another thing that hasn't been mentioned is the HIV program, because women living with HIV has 6 times more risk to developing cervical cancer. So how to really, bringing all this stakeholder at the state level together is something that when we go into start thinking about integrating HPV screening, something to think about on the upfront. Overall, once again, really honored to be in this partnership, and then sustainability is something we need to also talk about. We very often hear about the cost of HPV is what preventing from this being, scaled up. We're always still remaining at a project-based level. But I would like to encourage, instead of just talk about the cost, let's think about the costing. And WHO has a set of tools that can support countries for costing. There's the C4P tool, there's One Health tool, so it's really up to countries maybe working alongside with the elimination strategy, and at the same time thinking about costing, because we can be surprised. It's not just the cost itself that's prohibiting. It's maybe the whole chain of system provision, the resources, different areas that need to be actually strengthened before we can think about integrating HPV screening. Overall, in all our countries, we see, HPV screening, including self-sampling, is something that countries welcome. And there's political, commitment to have this. But then to how to really bring this into operation and scale up and, in a sustainable way is something that I think altogether we're still exploring. And hopefully that with the project keep on running, success is going to the second phase. We're expanding to more countries that we can, in the future, providing more information and evidence on how to, on the sustainability level. Thank you.
Thank you very much to our 3 panelists, to our 3 speakers. I would like to see if there is any question from the audience. I could see there is a question on vaccines that Veronica has kindly replied. I don't know if there is any question that you could see, Kirsty or Anne. Okay, so I think I first have to say thank you to the 3 of you. I think the work that both Jhpiego and the Success Project have been doing is excellent, and is actually supporting our efforts at WHO to, progress towards this elimination of cervical cancer. First, on the tools, I saw there are a number of tools, and they are fantastic, and I think it becomes like a library, of everything that anybody that is in a need to train people, to train new workers, to train lab people, to look at the quality of the lab, to train on visual inspection if you're going to use it as triage, following our algorithms at WHO. Everything is there. And I'm very pleased to see that this has been achieved and there is available. We have it even in the chat if anybody wants to look at these tools, and that they have been used, when you have started the Success Project. And then I have a question, because Anna presented to us all the, let's say, the main themes that you have found out that are essential to actually go and introduce HPV testing as part of, a screening program. And one of the issues that I have mentioned for both by Anna and by Lisa is the use of self-sampling. And we all know that cell sampling, and it's well demonstrated, there is enough evidence to say that it will increase the uptake of screening wherever we can use it. There may be some opposition, little opposition at the beginning. It just requires a better introduction or better explanation, both to women, to the public, to clinicians. But in the end, it will be increasing access. The problem that we can anticipate, and it's not a new problem, is the problem that we've had all over the years, is the follow-up of people that test positive. Because especially if cell sampling is done outside a clinic by a community health worker, for instance, then how are we going to make sure that these women actually complete the full spectrum of whatever it takes, if they are positive, if they need treatment, if they need to go to a higher level to have a LEDs, or even if they are discovered with a cancer. Eventually, we need to see that cancer, but we need to bring them back to the clinic. So I would like to hear from any of you three, what have been the main efforts that you've done to actually bring these women back? And can you, I know that we haven't seen numbers of your project or what has happened, and it's okay, but can you, in your perception of those things that you have tried, which have been the best ones?
Thank you, Maribel. Maybe I'm going to start and then others can add. Yes, you are completely right. This is one lessons learned that follow-up is challenging, not only for HPV tests, but also HIV, other tests that need multiple visits of women to the service. So what we have been learning in supporting countries for the introduction of HPV tests is the need of really reinforce the counseling, not only for increase awareness of the need of screen, but also of the follow-up and the necessary treatment. So we are even revising our IC material to really ensure that we do the complete message to the women since the beginning. Other areas is that sometimes there are much more emphasis on number of women screened than number of women treated. We have, for example, countries where the national information system just including information about the number of women screened, but they don't have the number of women treated. So this is something that we have been discussing with countries and building the capacity to really ensure that we have a strategy and straighten the system to follow the women from the beginning to the end. Thank you. Others?
If I can add on, I think it's also really important for the continuum of care where we do self-sampling that the capacity already exists at the community level. If there's no presence of the Ministry of Health at the community level, that's going to be harder than if there already is. So for example, here in Guatemala, there's nurses that are called territory nurses. So the communities are divided into territories, and then one nurse is in charge of each of these territories. So they are already organized in a way that they go out and they know that they have to visit X number of homes, and they already know who the people are in these homes, and there's already infrastructure there for other programs. So they might do vaccination, they might do a number of other things. So it's when you can build upon what already exists in order to do the HPV screening, it really improves the follow-up and the success, because then there's already a way for the woman to know that to get the result back and then to be visited and invited to go for her triage and then for her treatment. So what we learned here is that this can be much more successful when the Ministry of Health already has this infrastructure.
Thank you very much.
If I can complement really quickly,
Yes,
I think
go ahead.
patient navigation is something that in the Success Project we have been trying to explore from the outfront. So what we're seeing is on the very primary healthcare level, it's still very much paper-based, and the same healthcare worker might have something to fill out for the HIV program, for TB program, now for cancer screening or for other pathologies. So how do we support countries to really think of a system that it's better integrated, so that no woman is missed because a healthcare worker is not able to find a chart and have this management of data. And another thing is very often what we're seeing is in the project and across many countries, the turnaround time for the result is very important. Because having some woman screened on first day of the month and getting a result back in 2-3 weeks, it's probably easier to find her than returning the result in 2 to 3 months. So this is something the whole chain of health system needs to come and work together. It's not just about hard to find. It's about how we make the effort to make sure the whole thing is more efficient and effective.
Thank you very much. I think I will have another question for you, Lisa, to finalize. And of all the countries that you're working, so you're working in 10 countries around the world, where you have tried, to introduce HPV testing, not only the Success Project, but also Jhpiego. But from your experience, do you think those countries where you are working are ready or are prepared, or how long it will take for them to actually implement HPV testing at a national basis, so to scale up? And what will be the planning for the sustainability? Have you thought about that?
I think maybe Anna can answer for us, because Guatemala is really leading the work and really working, very, very closely and strongly with the government we are at the level of, getting the procurement ready. So maybe Anna can help us with this.
Thank you. So in Guatemala, there had been an HPV project back in 2015. And it was great while it lasted, and they did 100,000 tests, which is a huge amount. And then it stopped, and then nothing more happened. And then Success happened, and very happily now they have procured. I think it's a bit of having the country ready to go to procurement. I think that now the country is at a different level of maturity. The tests have have lowered their prices, even though in Guatemala they're still expensive because of internal issues. But despite that, I think that what Success did was sort of get a spark. And the good thing was that we were basically, if you look at the map, we're in almost all of the country. So that sort of set a spark in each of the areas. And so in Guatemala, the reason is there's a tax on alcohol, and so this sin tax is used for reproductive health. So this tax available, it's about $10 million for the whole country. So part of that is what's being used to procure the HPV tests. And it's also interesting because they put the money in each of the regions. So each region can choose what test they want. There's not a centralized mechanism, which would probably make the test cheaper. But on the other side, doing it regionally has allowed for each of the areas to figure out what's more accessible to them. So there are different issues to think through, but I would say the country's in a good place in terms of procurement and in terms of really having the sustainability to be able to continue. And of the Success sites, in most of them, they now have of the 19 health areas where we're working, 16 of those now have funding available to procure their own tests. So it'll be really interesting to see in 2024, and also to see when they send it to the lab, do they do it locally, and how that happens. But I would say the most important is that the need has been created among the women, and it's the women that are now demanding that they want the testing and also the treatment, because there's been enough done for the women to be able to be aware of that. So I hope to be able to let you know how it's going a year from now.
And if I can add, Guatemala, I think back in 2020, the national guideline already incorporates HPV testing. So on the political level, so all those political guidelines and that generates this internal and political discussion on integrating HPV and thermoablation. I think that's also very important, and that happened early enough for Guatemala. And then this whole system of, I think, through Success and thanks to Jhpiego's great work, we demonstrated different modality of operations, and I think the government is now really convinced that this will work in the country, and that's why I also generated this confidence in putting financial support into this. Thanks.
So thank you very much to the three of you. I just wanted to highlight that in the chat we've had some comments that there is the ROSE project in Malaysia that has also gone through all these procedures and probably has tried different ways of retention to women, to the treatment and the follow-up. So that is great, but I think we have to consider that when we are trying to address all these issues, each country, and not only each country, within a country, perhaps each of the localities or jurisdictions that you target may have their own needs and their own challenges. And we need to, the tools that so gladly Jhpiego has developed will need to be adapted before being adopted in these areas. So I think that is the part of, it's another issue of our work that we need to consider. And I would summarize some of the points. The first one is informing women well. Creating awareness is not only to say cancer is a problem. Creating awareness is letting women know, making as much as possible this relationship, sort of personal relationship with the woman, to tell her that she needs to attend screening and that she should complete. I think that's an important, that is an important part. The second point is that we really need the training of all the workforce in all the levels. The screening process, even if we use the simplified algorithms that we put in our guidelines, is complicated because you always need like not only one facility, but you probably need several people working on that. So we need to consider our workforce, train them well, explain to them what is the importance of their work, and then we will facilitate everything. And most importantly, I think the political will from a country is important, and the introduction of the guidelines or of HPV into the national guidelines is a start point. So with that, I would like to close this panel, and I thank you to the three of you and to the people that has been commenting in the chat and to the organizers for this nice discussion. Over.
Thank you, Maribel. And yes, I also echo your thanks to Anna, Veronica, and Lisa. It was fantastic to kick off the discussion, to see the launch of these tools. And there's quite a lot of comments and questions coming in the chat. We have very much started to touch on some of the topics that we'll be diving into more detail in the second panel and to really further explore this learning from implementation. So please keep the questions coming. We'll answer as many as we can, either on the chat or in the Q&A at the end. Sorry, excuse me. And now I'd very much just like to introduce Somesh Kumar, Senior Director, Technical Leadership and Innovation at Jhpiego and Country Director of Jhpiego in India, who has a lot of experience from many different countries doing this work and is really committed to facilitating access to strengthening the quality of global public health services in underserved regions around the world. As I said, it will touch on a number of these topics, such as access to screening, the care pathway, sample transportation and lab systems, and the pathway to scalability. So Somesh, I'll hand directly over to you to kick off or continue the discussion.
Thank you, Kirsty. After the global perspectives, we go to the what I'll say unashamedly the most exciting session of our meeting today. So we have representatives and leaders from 4 countries who will share their rich and diverse learnings from the various efforts for introduction of HPV test-based screening and thermal ablation programs and beyond for the secondary prevention of cervical cancer. So I will take just a minute to introduce them, the panelists quickly. So from Côte d'Ivoire, we have Dr. Adie Yao from Côte d'Ivoire. So Dr. Adie joined the cancer program in 2008 and holds the position of Head of Monitoring and Evaluation Department. He also serves as the Deputy Coordinating Director. He has participated in all cervical cancer secondary prevention projects implemented with the support of various partners. He holds a doctorate in medicine. From India, we have Professor Nuzhat Hussain, who is the professor and head of pathology at State Referral Center for Lab Investigations at Ram Manohar Lohia Institute of Medical Sciences, Lucknow, Uttar Pradesh, India. She has completed 2 extended terms as the dean, spanning over 7 years, and also headed the institution as a director. From Philippines, we have Carmen Orste. Carmen is a founding member and vice president of Cancer Coalition Philippines, which spearheaded the passage into law of the National Integrated Cancer Control Act, that seeks to transfer cancer care and significantly increase survivorship for all cancers in the Philippines. As a patient advocate, Carmen represents civil society in strategic strategic policy-making bodies such as the National Integrated Cancer Control Council, National Advisory Council for Medicines, and more. And finally, happy to introduce my friend from Mozambique, Dr. Alicia Jaramillo, who is the country director at Jhpiego in Mozambique. Dr. Jaramillo joined Jhpiego Mozambique in 2008 and has served in different capacities since then. She is currently the country director and COP for a project funded by CDC PEPFAR. In this project, Jhpiego, as a central partner, is providing technical assistance to the MOH to implement their priorities, including cervical cancer response. So I will start probably with India, with Professor Nuzhat, and ask her the first question, and then we go to our panelists one by one. So, Professor Nuzhat, you have recently introduced HPV test-based screening in Amethi district of Uttar Pradesh state of India. In the model, you have taken tests close to the women and in some cases within the homes of the women, which is pretty transformational considering where we were a few years ago to have cervical cancer screening or sample collection done within the homes of women living in villages of India. So can you talk about your experience of how you have gone about this journey and from the introduction of the test, HPV test for screening, as well as then decentralizing it to the homes? You're on mute, Professor Nuzhat.
Sorry. So yeah, thank you. So this is definitely a step up from the visual inspection and treat approach which we had earlier. And I must say that this is a commendable initiative taken by Jhpiego along with the state government, healthcare partners. And this program has been initiated in the Jagdishpur block of the Amethi district in Uttar Pradesh, which is incidentally the most populous state in India. So we've started with an attempt to replicate a model where, to create a model which can be replicated with a catchment area of about 10 health centers, and these are under 2 PHCs. And we are attempting to cover a population of almost like 14,000 women above the age of 30 years, between 30 and 65. And we intend to reach about 70% of the eligible women, which is about a 10,000 number, using the HPV DNA screening approach. And then we will then bring these women for treatment by thermal ablation to the community health center, wherein the medical officers and all have been trained to do the procedures. So the initial step of implementation of this program was capacity building. And this we started first at the center itself, where the ASHA worker, the accredited social health care activist called the ASHA, which actually means hope. She works with the community level, and she motivated these women to come to the CHC twice in either on Tuesdays and Thursdays. And then these women, they were tested at these centers. They were counseled, and the health workers, they were kind of trained under guidance and these how to facilitate these women, how to collect their samples. So this initial facility based approach created community awareness. The women in the area became aware that a new initiative for cervical cancer screening had started, and also a practical ASHA workers then started doing a home-based collection. And then the response of this home-based collection was actually excellent. And almost 100% of the women who were given these vials for self-collection, they returned them back. So half of these samples, then we also tested both a centralized and a hub approach using a hub and spoke model, as well as a rapid point of care device at the CHC. So 50% of the samples are being transported to the hub, which is at the molecular pathology lab of our institute. And the rapid point of care device is being used for another 5,000 samples. And these samples get transported twice a week, and to the hub, and the reports, they are signed out online and printed from a network and computing facility which has been established at the spokes.
So can you talk about, you mentioned about the centralized and decentralized testing and how you have kind of optimized the use of the two kinds of platforms for both equity and access. So can you talk about how you have gone about doing that and why?
So I feel that both the models have their value in our screening program. With the centralized model, we can more efficiently cover large number of tests. And, and there is more like standardization. The quality control issues are easier. However, it increases the turnaround time because of the transport time that is taken. If this model needs to be replicated, I think, as Anna suggested, you will have to have multiple centers with less distance. Currently, our distance is about 100 kilometers, so the sample gets to us in about 3 hours. With the decentralized testing, the testing is closer to community, but ensuring the availability of technicians, maintaining a supply chain at the near point of care device is a challenge. So in both instances, a pre-assessment on the required capacity is required, and an adequate infrastructure needs to be built in so that the test reports can be provided in a short turnaround time, because that's very crucial for continuation of the recruitment of the patients for treatment.
Thank you, Professor Nuzhat. Dr. Adiye, I'll come to you next. So Cote d'Ivoire has done remarkably well in demonstrating effective and viable service delivery for HPV screening. And you have specifically done some excellent work in integrating HPV test-based screening in your HIV service delivery platform, which is something that we all want to learn from. So can you talk about your learnings from how you have gone about screening the HPV test-based screening in the HIV platforms? What have been your learnings and some of the challenges and how you have overcome them, Dr. Adiye?
Hello, good morning, everyone. Thanks for this panel. Yes, as part of the fight against cancer, we have implemented a secondary prevention cancer prevention with innovative approach using the HPV test and thermal ablation. So the use of a different platform was facilitated by a certain achievement before this project using HPV testing. In 10 years, with the support of Jhpiego, we implemented a cervical cancer screening project using VIA. And at that time, we have set up a technical working group on cervical cancer with the participation of various stakeholders, including HIV program and HIV partners. So we work together in this first project. And secondary, the HIV program had a funding from Global Fund for another project with VIA. And on this project, we worked together. So when the new project was presented with its innovative approaches, it was very, very well received. In this project, our screening objective was set at 70% of women living with HIV. So one of the criteria for choosing health facilities was the number of women living with HIV in these facilities. And our choice was made with the support of HIV program. And we did an assessment of laboratories in the project, implementation areas to know how many platforms you have, what kind of platform you have. There were laboratory using for HPV testing and TB testing. So we use the both kinds of machines. For the public health center, there is no difficulties. But for the research laboratories, we have to sign a MOU to use their platform because they are not the public health facilities. So to summarize, I can say that the collaboration with the HIV program from the first project made things easier for us on this new project using HIV testing and thermal ablation. Thank you.
Thank you, Dr. Aliye. So I'll probably follow up the question with another question. Your program has also done, encouragingly well in getting women back for VIA assisted triaging or VIA for treatment, where you have got upwards of now 63-64% women who are back after being HPV tested positive. So how have you, and I know this is, you are working more on getting more and more women to reach that 90% target. So how have you gone about getting the women who are HPV positive back for treatment? Because this was a question that came up in the chat as well, and I know you have done some deployed a lot of differential strategies for doing that. So can you share some experiences there?
Thank you very much. So when we began the Success Project, we have set up a system for monitoring women for the DHS2 tracker. So as soon as women have been sampled for HPV testing, they are registered in the tracker and the sample is referred to the laboratory for the tracker, while the physical sample leaves for the laboratory. When the analysis is completed, the laboratory informs the tracker and the service providers immediately have the results. So the woman who was sampled received a message inviting her to go to the facilities to get her test results. After a few days, if she don't go to this facility, the healthcare provider call her to invite her to come to the center. But sometimes the women don't come. So the health provider may call several times. So yes, we have a good rate, but we think it is not enough. So now today we are considering the use of a community approach to increase this rate. Thank you.
Thank you, Dr. Aliye. Professor Nuzhat, you have also deployed some of these strategies, and I know you're starting now last couple of months only for the treatment because of your program. So, but what are your some initial learnings from the community mobilization strategies for getting these women and all other strategies that you are deploying to get these women back for treatment, the ones who are HPV positive, rather triaging and treatment?
Yeah, so we have a good network, and the positive reports, they are communicated to the patients, to the women at home by the ASHA workers. And also we've got like a preset counseling message with individualized patient's name in Hindi, which is also sent to these to the positive woman. And also if we have a phone number, we send a message to the woman on the WhatsApp or the messaging as well. So, and then she's kind of followed up and recruited to come to the center. The centers are not very far off, so it's kind of easier for them to get there to the CHC. And the medical officers at the CHCs, they have been trained to provide the thermal ablation at that point.
So you said decentralized testing is decentralizing treatment is helpful because if
yes,
the treatment
definitely,
is
because
closer,
having it at a closed center and making it like a day procedure in which she can kind of get it done and go back. The other thing that we feel very important is the pre and post procedure counseling, because it's very critical to communicate the method of the procedure as well as, you know, mild side effects like, you know, discharge and all, which can occur after the procedure, and that can prevent anxiety, and for the woman, you know, she doesn't go back with a negative feedback to the community, because that kind of a personal feedback into that the village community actually causes a lot of misconceptions, and women don't want to come back. So sort of a personalized counseling which can be achieved through these healthcare workers who directly go to their homes is quite helpful.
yeah, we learned about the importance of counseling earlier, you know, in some family planning programs. Because if people do not know that after a method there's going to be a side effect, then they will feel that something is wrong about it. So if you preempt that and tell them, then it's expected and it's something that they know is not a health hazard, but it's something that comes with the method. So thank you, Dr. Rosat. So Carmen, I'll come to you next. And I understand, and I'm sticking to this theme itself on mobilizing women for both screening and treatment. And I know you are playing some leadership role in mobilizing CSOs in getting the women for or rather creating demand for from women and communities for accessing HPV-based screening as well as treatment. So can you talk about that experience? How are you leveraging the CSOs, and what are the learnings from this experiment that you are doing?
Well, a major barrier in the Philippines in terms of women seeking screening services, even if it is free as provided by the success project sites, is the fear that if there is a finding of potential or possible malignancy, they don't have the necessary financing or funds to be able to continue with further diagnostics and treatment. So because of that, there were several strategies that were adopted. One that I'd like to start off with in terms of mobilizing is, you know, in our country, we have a lot of what others would call festivals. We call fiestas, which is really a community gathering where people come to sing, dance, and of course eat a lot, just like in India and other countries here. And so some of the health facilities in the Success Project, what they actually did was, in order to create buzz, first, they went around the community. They had mini, you know, like town hall meetings where men were involved as well, and other influentials, including political leaders. And then they all got invited to come together in one day. So in effect, it was like a massive screening. But see, in the Philippines, our health events have to be social events as well, for people to dispel whatever fears they have. So that was one that was very effective in terms of bringing them in. And then there were tents that were set up in order to be able to assist them to go through the process of being able to do it themselves, which surprisingly people thought that there was going to be an objection, but it was actually very well accepted. The second aspect was, of course, being able to have patient navigators. Some LGUs, we have what we call community volunteer health workers or barangay health workers. So some have now actually trained them such that they have a separate patient navigator for breast cancer patients, and then a separate one for those that need to go through the care pathway for cervical care and cervical cancer. And what they have found is, as you said, when you were speaking about the importance of counseling, that it helps if there is someone that they can talk to, clarify things. And again, in our country, where there's a very high financial toxicity in terms of when treatment is required for cervical cancer. What happens is they also play the role of financial navigators, assisting them to be able to identify where are the sources of funds, how to fill up forms and requirements, and in addition as well providing support to the family and the children, because most often when it comes to women's cancers, we forget that, like in the picture that was shown, you know, together with the mom is a whole family and the children especially. So I think in the Philippines, that's part of what CSOs are emphasizing as well, that we not only care for the patient, but we care for the family, and we're making them aware, at least the political leaders and the decision makers, in terms of the generational trauma of cancer, so that it is something that needs to be addressed holistically.
And Carmen, Philippines has also taken some decisive steps in the movement or the transition to scale of HPV test-based screening. So can you talk about that journey and how, again, from your vantage point, CSOs have played an important role? Because it might be a good learning and a lesson for some of our other countries where transition to scale is something that, given the costs of the diagnostics, etc., HPV tests are not procured, and it may go down in the priority list of our policy makers. So, any learnings and experiences from that space?
Well, a very specific move that the coalition and other members of the cancer community did was, of course, advocating for the passage of the National Integrated Cancer Control Act, which was signed into law in 2019. The Philippines operates actually on a devolved or decentralized setup where our local political leaders, from the governors in the provinces to the mayors in the municipalities and cities, are actually the head of our local government units. What we have now done is we have moved down the NICA implementation to what we call localization. And this is both in terms of scaling up cervical cancer services, as well as 6 other cancer services, and also ensuring sustainability, because the local government units have their own funds. So while in the initial stage of the success project, they were being engaged to utilize what we refer to as gender and development funds. These are gender and development funds, not just for women, but for men as well now. And the health component was not really made explicit, but through our advocacy, we informed them that it was something that can be used to support patients. But in addition to that, now, as part of the localization, we have developed a screening tool for the primary healthcare units, where they're able to assess both their readiness to be able to conduct, for example, the services that are required for HPV-DNA screening, or in some areas not yet ready for HPV-DNA screening, to be able to do the BIA testing instead. And as well, the 6 other cancers, which are breast cancer, lung cancer, prostate cancer, and colon cancer, which are part of the index cancers, and as well childhood cancers. So as part of that localization, there is first a gathering, not just of the government hospitals. We have areas where we have no government hospitals, no tertiary level that could be the referral center for cancer. So we have actually reached out to private hospitals. And in the Philippine system, we have what we call guarantee letter, or like cash vouchers. And we have been able, in some areas now, to convince the private hospitals to start accepting these cash vouchers or guarantee letters, which the government provides. So indigents and financially incapacitated patients, or women in this case, who are referred to the hospital for further diagnostic and treatment and care, can have care even if they're in a private hospital. The other thing that we have as part of the law is what is known as the Cancer Assistance Fund, which right now is housed in government hospitals. There are 35 access sites, but part of the law as well, which we are now advocating and pushing hard for, is what we call shared care, wherein if the government hospital does not have the required facilities, again, through a voucher system, they can first do a MOA with a private hospital and then engage and pay for the services of that patient utilizing the funds from the cancer assistance. And there is also what we call the CSP map, which essentially is free medicines, again, for 8 cancers, and cervical cancer is one of those. So we are very hopeful that moving not just on the national level, but really on the local level, that things could be more accelerated in terms of scalability and sustainability. And of course, thank you for all those who made the Success Project happen in our country.
Excellent. Thank you, Carmen. Extremely rich learnings on the pathway, and to see success obviously is very fulfilling. So I'll go now to my colleague from Mozambique and friend Alicia. So Alicia, I'll stick with the same topic and on the sustainability and transition to scale. And I know Mozambique in some ways is a leader in this space in Africa, as one of the few countries who has developed the elimination strategy with the globally aligned goals for 2030. So wanted to ask you what catalyzed and how this development of this strategy, and how are you leveraging this strategy, or how do you propose to leverage this strategy for accelerating access and utilization of secondary prevention services, but not only secondary, primary and tertiary as well, because this is obviously a comprehensive elimination strategy. So over to you, Alicia.
Thank you very much for this opportunity. I will respond to your questions in part. So first, I will mention something about what led Mozambique to develop the elimination strategy. I will talk a little bit about the process and the progress that we are doing so far. So in terms of what led the Mozambique to develop the elimination strategy, we can mention 3 reasons. So the first one is the urgent need for intervention. The second is the political decision. And the third one is the need or the opportunity for the integration. First, in terms of the need for intervention, so Mozambique has a dramatically incidence about cervical cancer. So as you know, in 2020, Mozambique was among the top 10 countries with the highest rate of incidence and mortality due to the cervical cancer. In 2021, the age-adjusted incidence is estimated in 50 cases for 100,000 women. So if the situation remains the same, the number of cases and death in women due to cervical cancer is projected to increase by 95% in 2040. So the second thing is the political decisions. Under this critical situation, the First Lady is leading personally this initiative, which is great. And the Ministry of Health, with the support of the partner agencies, especially Jhpiego, with funds of PEPFAR, has been investing in cervical cancer prevention and control since 2009, when the government launched the National Cervical and Breast Cancer Prevention Control Program. And it has been working over the past year to implement and consolidate. But it is a problem in countries with a scarcity of resources, right? So all of us know that this is very challenging situation. And in Mozambique, this is very true. So that is why the third thing is very important, because the opportunity for integration provides us this way to go ahead. So since its inception, cervical cancer has been integrated into the sexual reproductive health, family planning, and HIV services. That is why the program is being implemented despite the scarcity of resources and funds. In terms of the process, so in 2021, the Ministry of Health and Donor established the National Technical Working Group for Cervical Cancer Prevention and Control to ensure that this technical working group will be implementing the World Health Organization recommendation. This is something very important to ensure that is what is in the world could be made real. So since 2022, Jhpiego as a central partner has been invited to support this task force. This group worked very hard and very motivated. And in a very short time, they prepared the national roadmap towards the elimination of cervical cancer. And this strategic document has been approved by the Ministry of Health. So meaning that we have the way to implement everything, organizing the whole country. So along the roadmap, there is a review and update of the strategic documents to put the pieces together at the fieldwork. So in this way, for example, it is updating the norms and technical guidance, training package, information system, performance quality standards, among others. But it's not enough because everything is in concrete, in writing, the document, that's it. But for us, the strategic part was putting in each of the regions one piece of technical assistance, which is the training, the master training in the north and the center and the south. So this key staff is providing technical assistance to the provincial and local level to ensure that what is in the roadmap should be implemented in the real life. So following all the quality standards and everything. So they are coaching, training, monitoring, supervision, etc., with the leadership and participation with the Ministry of Health at the provincial level and local level. So we are working together. So now I will mention a summary of what is in progress right now in Mozambique. In terms of primary prevention, the Ministry of Health, with Gavi's support, managing to introduce and scale up the HPV vaccines for girls to new years old. And this could be extended to 14 years old. In secondary prevention for primary care level, Jhpiego provides support to the Ministry of Health in screening for BIA and treatment of precancer lesions and cryotherapy and thermoablation. In referral health center, colposcopy and lip services are available. And Jhpiego is providing technical support to the Ministry of Health to implement also the HPV DNA testing in 4 facilities, meaning that we are working in several ways, and the primary, secondary, and also in the tertiary prevention. So all cases that are identified in primary health services are transferred for referral services where they are confirmed. These cases are discussed through the telehealth by a national multidisciplinary team that defines and supports the treatment. Those are some examples how in an environment with scarcity of results, we are trying to move forward to implement this national strategic program. Thank you.
Wow, that is so inspiring, and lot of strategies of how you have integrated not only at service delivery but at policy level. And this is a learning that, you know, we think about integration at the service delivery level, but you've gone about integrating at a policy level and different parts of the health system. So, you know, we have around 6 minutes probably on this. So Bill, and maybe I have 3 minutes or so. So maybe we'll break for some questions from the audience. If there are questions in the chat, or if not, I can start. So I'm looking at the chat now. Anybody?
There've been quite a lot of questions, but a lot of them have been answered already by different speakers. So I think you can carry on.
Okay, then maybe one quick last question to Alicia before we close, and please ask any question. Feel free to ask any question, more questions in chat. Alicia, you have also in Mozambique, rather the government is trying to mobilize resources from different sources of funding for HPV test procurement and thermal ablation as well. Very quickly, how are you doing that? Anything that comes to your mind that you want to share with the audience?
Yeah, so following the roadmap, the Ministry of Health envisioned to ensure immunization, screening, treatment, and effective referral. That is the summary of the roadmap. So considering the updated version or recommendation of the World Health Organizations to use the HPV testing, and after the result of several studies that can be conducted in Mozambique, after the results, the Ministry of Health is preparing to transition to the introduction and scale up of HIV screening. So at this point, actively, we are working for funds. So we prepared several proposals, and for the partner donors and also for private sector. After successive advocacy activities, including workshops, etc., now we know that the Global Fund will provide some support to get the HPV test funding. And in terms of thermal ablation, currently we are implementing in 40% of the health facilities, and our ambition is to scale up to all of them that are providing a screening for HPV. That's it.
Thank you, Alicia. So very rich learnings from 4 different archetypes of health systems, from Mozambique to Philippines, and then from India to Cote d'Ivoire. Different opportunities and thereby unique learnings coming up from our leaders. So, I mean, key themes, different countries have adopted different strategies for community mobilization, from community gathering, leveraging community gatherings, fiestas in Philippines, to leveraging the community health structure, worker structure in India, ASHAs, service delivery, a lot of lessons from integration from Cote d'Ivoire, optimizing lab systems from most countries, as well as for the continuum completion, the treatment, ensuring the treatment for women who are HPV positive or triaging and treatment. A lot of strategies were discussed, and finally for transition to scale, very strategic approach from a Mozambique to Philippines on how the different partners have approached it for advocacy, be it integration in other programs, or in some cases in Philippines, for example, legislation. So great variety and spectrum of learnings from across the value chain, if you will, from a demand generation to final policy and political decision making. And so it's such a privilege to be moderating such a rich session from different parts of the world. So with this, I thank all my panelists, and I really, I hand it over back to Kirsty for the closing remarks.
Thank you so much. And I fully echo your comments there. I think it's been really, I just really want to thank you all for joining us for this discussion and to really explore what it looks like to implement the recommendations, the different interventions of the global strategy. There's certainly a lot of lessons already learned, a lot of pieces in progress. And so, yeah, really want to please continue to post any other questions in the chat. We'll try and respond to them. And really just thank you all for your participation. As was highlighted in the chat earlier, the resources have been shared. The slides that were shared earlier will be shared as a follow-up to this call. They'll be made available also via the UIC website link. And we'll follow up with you very, very shortly with all of that. And I really hope that this discussion serves you in your future discussions and reflections on the different areas of work that you're leading. We will be hosting another virtual dialogue on cervical cancer elimination, focusing very much on this question of scale and sustainability in the coming months. So please look out for that date and join us for that discussion as well. Thank you again to all the speakers and panelists and to all of you for participating. Thank you. Goodbye.